Hello friends, today we are going to discuss about the PKPD of the critical illness. The management of infection in the intensive care unit represents the ongoing challenge for critical care clinicians. The critically ill represents the unique population either presenting with the infection complicated by systemic inflammation or being predisposed to such a complication by virtue of underlying disease process. Multi-trauma, hematological malignancy, and acute kidney injury are relevant examples where organ function is already significantly disturbed while subsequent infection is common. Successful therapy relies on the early recognition of infection and the timely application of antibiotics against the contributing pathogen. Modest evidence support this as an effective intervention that will improve the outcome. However, mortality rates in this setting remain high, while antibiotic resistance is becoming more prevalent, suggesting further movements are urgently needed. So, the optimization of antibiotic doses, such as predefined PKPD target for maximum bacterial killing, are achieved and has been proposed as one such approach. So, utilizing the contemporary data, the aim of this discussion are therefore to illustrate how critically ill patients differ from the non-critically ill in terms of their antibiotic dosing requirement. Examine the role of alternative dosing strategy in the critical illness. Provide clinicians with the practical prescribing advice, which attempts to improve antibiotic exposure and patient outcomes in this setting. Now, the antibiotic PKPD in the critical illness, volume of distribution, clearance, and protein binding and microbial susceptibility. Critical illness is characterized by the marked homeostatic disturbances, altered end-organ function, variable pre-existing comorbidity, and anthropometric irregularity. Such a changes will significantly distort the normal antibiotic PK profile, resulting in drug exposure that is markedly different from healthy volunteers. Complicating this is the increasing prevalence of microbial isolate with decreased susceptibility, mandating the application of higher antibiotic concentration for successful bacterial killing. So what happens in sepsis? Whenever there is a sepsis results in the sepsis or any other condition which results into the systemic inflammation, it results in altered major organ blood flow, endothelial dysfunction, and capillary leakage. So because of this, there is decreased clearance and increased volume of distribution, which reduces. And the additional factor which are contributing to this is larger volume IV IV fluid resuscitation, obesity, vasopressor medication, extracorporeal circuit, low plasma protein concentration, and drug-to-drug interaction. All these things reduces the antibiotic exposure plus and higher MIC, which leads into the treatment failure. So we'll see each one of these in detail. So first is volume of distribution. Key physiochemical properties including molecular weight, degree of ionization, protein binding, lipid solubility will greatly influence the antibiotic distribution. Lipophilic agent like fluoroquinolone typically have large volume of distribution with the greater tissue and intracellular penetration. Alternatively, hydrophilic antibiotic will primarily distribute into the extracellular space. As such, an increased volume of distribution has been demonstrated with aminoglycoside, beta-lactam, daptomycin, and glycopeptide in critically ill. This likely reflects the significant capillary leak coupled with aggressive fluid load, which expands the interstitial space. Higher acute physiological and chronic health evaluation, that is Apache 2 score, have also been correlated with the larger volume of distribution for aminoglycoside and vancomycin. These data suggest an important interaction between illness severity and antibiotic pharmacokinetic, which is infrequently considered in most contemporary dosing regimens. Obesity represents an increasing challenge for accurate drug dosing in the critically ill. Of note, the recent data suggests an association between obesity and antibiotic treatment failure in large community-based cohort studies. In addition, separate reports have documented subtherapeutic concentration of linezolid and the cefoxitin in this setting, potentially contributing to adverse clinical outcome. As current data are relatively sparse, the few absolute recommendations can be made. Recent data concerning doripenem in critically ill patients, that is 100 kg with nosocomial pneumonia, indicating that extended infusion provide improved target attainment with susceptible bacteria. Similar data have been reported with the piperacillin tazobactam in obese patients, where higher doses and extended infusion were required to achieve adequate drug exposure. As such, at extreme of body habitus, higher empirical beta-lactam dosing should be regularly considered. So practical tip is aminoglycoside dosing should be calculated on the basis of adjusted body weight. Daptomycin and beta-lactam adjustment should utilize lean body weight, and vancomycin dosing should be based on total body weight. So next is clearance. Many commonly prescribed antibiotics are primarily cleared from the body by renal elimination, including beta-lactam, aminoglycoside, and vancomycin. Acute kidney injury and continuous renal replacement therapy. So the application of extracorporeal support for acute kidney injury in the form of intermittent or CRRT significantly confound the antibiotic dosing. In these circumstances, the factors such as drug molecular weight, protein binding, hydrophilicity, mode of renal replacement therapy, filter porosity, blood flow rate, and total effluent rate will all influence extracorporeal drug handling. So, varying clinical characteristic, timing of CRRT, filter lifespan, circuit changes make accurate PKPD modeling problematic. As such, antibiotic dosing is generally empirical, producing significant intra and interpatient variability in drug concentration, which are often suboptimal. So, how this impacts the clinical outcome remain uncertain, although AKI frequently complicates sepsis and remains an independent predictor of poor outcome. This demonstrates inconsistent recommendation, primarily related to heterogeneity in the CRRT prescription and clinical characteristics. Emerging data suggests that the intensity of the CRRT and the degree of residual renal function are crucial factors in accurately determining the antibiotic required. So the loading dose of 35 mg per kg for vancomycin followed by 14 mg per kg per day continuous infusion has recently been recommended during CRRT, although very high concentrations may noted initially, suggesting that 20 mg per kg may be more appropriate loading dose. Other recommendations include cefepime, that is 2 gram every 12 hourly, daptomycin 8 mg per kg 48 hourly, and the use of non-AKI doses with both polymyxin B and colistin. In contrast, higher doses, that is 400 mg of fluconazole, are needed because of the absence of renal tubular reabsorption. Now about practical tip. Antibiotic pharmacokinetic during CRRT is highly variable and dosing regimen relevant to institutional practice should be established locally. So current data suggests the beta-lactam dosing should be similar to that employed in patients without renal failure in first 48 hours of treatment. Now the next concept is augmented renal clearance. Augmented renal clearance refers to enhanced renal elimination of circulating solids such as waste product and drugs. This is based in part on PK studies demonstrating elevated renal clearance of beta-lactam, aminoglycoside, glycopeptide in varying subset of critically ill patients. So the clinically useful measure of this phenomenon is timely urine creatinine clearance. Use of this surrogate is reinforced by its significance as PK covariate for the renally eliminated agent and observed association between elevated measures and suboptimal antibiotic concentrations. So numerous at-risk population have been reported, including multi-trauma patient, traumatic brain injury, meningitis, post-operative patient, burn injury, ventilator-associated pneumonia, and pregnancy. Overall, the prevalence of augmented renal clearance varies considerably. That is 30% to 85% of study precipitate. Although this is heavily influenced by case mix and definition. Younger age and the lower illness severity score have been repeatedly identified in patients manifesting augmented renal clearance. As such, the interaction between physiological reserve and systemic inflammation appear to be the key driver. This was further substantiated in the recent report by Shimato et al., in which increasing number of the search criteria were strongly associated with higher drug clearance and the lower plasma concentration in non-ventilated critically ill patients receiving standard doses of vancomycin. The relevance of this finding to future dosing schedule is uncertain. While outcome data are limited, the recent prospective and single center observational study has demonstrated an association between augmented renal clearance and therapeutic failure in critically ill patients receiving anti-infective therapy. The implication for future clinical study of new or emerging antibiotic are therefore significant. An illustration interim data analysis revealed greater morbidity and lower clinical cure in patients with ventilator-associated pneumonia treated with fixed course of doripenem compared with imipenem or cilastin. These findings were most marked in the subgroup with estimated creatinine clearance of 150 ml per minute. Of note, separate PKPD modeling had suggested that significantly higher daily doripenem doses, that is up to 2 gram 8 hourly, might have been required for adequate drug exposure in this patient. The role of mathematical estimate in identifying augmented renal clearance remain controversial. So plasma creatinine based equations such as Cockcroft-Gault modification of diet in the renal disease and the chronic kidney disease epidemiological collaboration were primarily designed for use in ambulatory and the ward-based setting. They fail to consider the unique setting of critical illness, such as comparison with the measured creatinine clearance value, have revealed the limited accuracy, particularly in patients manifesting augmented renal clearance. As such, urinary creatinine clearance appear to be the most pragmatic, repeatable number measures of renal function available to accurately guide dose selection. So about the practical tip, measured creatinine clearance of 130 ml per minute per 1.73 meter square have been associated with subtherapeutic beta-lactam concentration in critically ill patients receiving standard doses and should prompt the clinician to consider alternative dosing. 8-hour urine collection appear to provide best balance between feasibility and the accuracy. Finding the free fraction of the drug is that responsible for the pharmacological efficacy and toxicity. In addition to being the fraction readily available for clearance via elimination pathway, the measurement of the free drug concentration will therefore provide more useful PKPD data, although this is not widely acceptable. Using established PK principle and increased fraction of drug will result in larger volume of distribution, as has been noted in beta-lactam, aminoglycoside, and glycopeptide. Similar changes are appreciable for the drug clearance, where increasing fraction of the drug prompts the more rapid renal drug elimination. Hypoalbuminemia represents the common finding in critically ill with pharmacokinetic of ceftriaxone, flucloxacillin, teicoplanin, daptomycin, and ertapenem all markedly alter in this setting. While the specific correction rule for dosing are currently lacking, Albumin concentration were often 25 gram per liter in this setting provide useful starting point to consider higher empirical dose. Additional PKPD analysis are required, although it is likely that higher total daily dose, more frequently administration, and use of extended and continuous infusion may be required to achieve optimal drug exposure. About practical tip, hypoalbuminemia is the only likely to influence the antibiotic pharmacokinetic when agent is highly protein bound and predominantly renally eliminated. Examples are flucloxacillin, ertapenem, ceftriaxone, and teicoplanin. Now about microbial susceptibility. Changes in the bacterial susceptibility represents the growing concern for medical practice globally. Knowledge of the likely minimum inhibitory concentration of infecting pathogen is crucial to accurately guide dose selection, as this denotes the denominator in the PKPD relationship. Not surprisingly, dosing stimulations suggest that higher MIC values, conventional strategies are unlikely to achieve required antibiotic exposure. While the local institutional data are preferred where these are not available, the worst case scenario approach to dosing should be employed. In this respect, less susceptible pathogens are frequently isolated in the critical care unit, while wide variation in the susceptibility pattern have been observed internationally. The role of alternative dosing strategies in the setting of less susceptible bacteria remain untested in prospective fashion. The retrospective cohort analysis improved outcome with Pseudomonas aeruginosa infection were observed with the use of extended infusion of beta-lactam. Higher colistin doses have also been demonstrated to independently predict microbiological success in patients with multi-drug resistance gram-negative infection. Of concern, current ciprofloxacin dosing regimen may promote the development of bacterial resistance, particularly with Pseudomonas aeruginosa and Acinetobacter baumannii infection. So, about the practical tip, the European Committee on Antimicrobial Susceptibility and Testing provide useful epidemiological susceptibility data for dose optimization and in the absence of local laboratory antibiogram. These considerations make it clear that one dose fits all approach to antibiotic therapy, although logically attractive, is grossly flawed in the ICU. This stems from the drug development program in which dosing schedules are assessed for clinical tolerability and efficacy in non-critically ill cohort. So the dosing regimen are simply extrapolated into varying subpopulation, which in critically ill may result in suboptimal outcome. Over the last decade, number of alternative dosing strategies have been proposed in order to improve antibiotic exposure in this setting. So this is summarized in the following table. So potential dosing solution for altered antibiotic PKPD in critical illnesses for larger volume of distribution and appropriate weight adjusted loading doses is needed. For ACare requiring CRRT, individual patient dosing based on physicochemical properties, intensity of CRRT, and native renal function, and about this therapeutic drug monitoring. Then augmented renal clearance, increase the total daily dose. More frequent dosing is required, and also we need to correct this by continuous and extended infusion and by therapeutic drug monitoring. If there is altered unbound free drug fraction, then we need to give the larger loading dose, increase frequency of dosing, continuous and extended infusion, and therapeutic drug monitoring. If there is a reduced bacterial susceptibility, then this problem we can tackle with increase total daily dose, continuous or extended infusion, application of PKPD models, and therapeutic drug monitoring. Now, the future dosing strategy, that is methods to improve antibiotic exposure. Much of the data supporting newer approaches to antibiotic dosing in critically illness are based on PKPD endpoint, reinforcing the need for ongoing well-designed, large-scale clinical investigation. Dose selection should always consider the unique PKPD concentration of chosen agent and patient's physiology and underlying comorbidity and likely pathogen. So this subsequent table will provide example of some common empirical antibiotic doses employed in our ICU in patient without AKI. So these are based on existing data on institutional experience with therapeutic drug monitoring of different antibiotic in critical illness. Now about loading dose. Loading dose are primarily employed to ensure therapeutic concentration are achieved rapidly, promoting fast and efficient bacterial cleaning. Mathematically, this is expressed as product of desired plasma concentration and apparent volume distribution. After bolus IV administration, plasma antibiotic concentration fall rapidly, primarily as a consequences of drug distribution. As such, in setting of larger than the anticipated volume of distribution, standard doses are likely to result in suboptimal drug exposure. So this is the table which demonstrated the intravenous antibiotic dose in critically ill patient without acute kidney injury. For aminoglycoside, it is in aminoglycoside group, gentamicin 7 mg per kg 24 hourly, amikacin 30 mg per kg 24 hourly. In beta-lactam, flucloxacin 2 gram 4 hourly, amoxicillin 2 gram every 4 to 6 hourly, ceftriaxone 1 gram 12 hourly, cefepime 2 gram 8 hourly, ceftazidime 2 gram every 6 hourly, imipenem 0.5 to 1 gram every 6 hourly. Then piperacillin tazobactam 4.5 gram, ticarcillin clownic acid 3.1 gram every 4 to 6 hourly, meropenem 1 gram every 6 hourly, 2 gram for CNS infection, ertapenem 1 gram every 12 hours. Glycopeptide vancomycin 35 mg per kg of total body weight, loading dose followed by 30 mg per kg per day continuous dose. Ticoplanin 12 mg per kg 12 hourly for 3 doses followed by 6 mg per kg 24 hours. Then ciprofluoroquinolones include ciprofloxacin 400 mg every 8 hourly, levofloxacin 750 to 1000 mg every 12 hourly, moxifloxacin 400 mg every 12 hours. Then in miscellaneous doses, drugs, linezolid 600 mg every 12 hourly, daptomycin 8 to 12 mg per kg every 12 hourly, lincosamide 600 to 900 mg every 8 hourly, tigecycline 100 mg loading dose followed by 50 mg every 12 hourly, colistin dosing according to the Garonix. In earlier studies of aminoglycoside, higher Cmax or MIC ratio were strongly associated with therapeutic success in the graded fashion. In patients without renal dysfunction, adequate weight adjusted doses are therefore mandatory to ensure adequate PKPD exposure is achieved. Rotacon and colleagues recently reinforced the importance of this strategy, demonstrating that doses of 12 mg per kg of amikacin were required to ensure therapeutic concentration against the Pseudomonas aerogenes. This was largely due to 60% increase in the volume of distribution when compared to healthy volunteers. The importance of employing loading dose in the critically ill patient receiving vancomycin has also been recently noted. Specifically, doses of 30 to 35 mg per kg of total body weight have been recommended to rapidly achieve therapeutic concentration. Convenience doses are unlikely to be adequate, with the recent data confirming the benefit of establishing local dosing protocol. Loading doses are also recommended for ticoplanin and higher doses advocated in the septic patient. Insufficient beta-lactam concentration in association with larger volume of distribution have also been demonstrated in critically ill, although arguably more attention has focused on the role of continuous infusion with this agent. In small single center study, Mohammed and colleague examined the use of 480 mg colistin methanesulfonate as an loading dose in 10 critically ill patients infected with MDR gram-negative bacteria. Modeling prediction of grow bacteria growth demonstrated that this approach significantly reduced the time to bacterial eradication compared to maintenance therapy alone. Of note, no significant nephrotoxicity was reported. Similar data emerged with the tigecycline, where higher loading doses have been associated with improved clinical cure in patients with hospital-acquired pneumonia without additional safety concerns. So the loading doses have also been recommended with polymyxin B. About practical tip, clinicians should consider the use of higher initial dose of aminoglycoside, beta-lactam, glycopeptide, tigecycline, colistin in septic and the critically ill patient, and subsequent doses can be modified on the basis of drug eliminating organ function. Now about continuous and extended infusion. Maintaining sufficient drug concentration throughout the dosing interval represents the logical approach when prescribing time-dependent antibiotics such as beta-lactam. Option includes more frequent administration or use of continuous or extended infusion. For intermittent administration, the dosing interval will be determined by the drug clearance, which is often influenced by renal function. So adequate loading doses should still be employed with continuous infusion in order to prevent prolonged exposure to subtherapeutic concentration. In this respect, the numerous small studies have demonstrated distinct pharmacokinetic advantage to the continuous infusion, although clear clinical benefit remain to be fully established. So continuous infusion should be commenced post-loading dose at a point no further than halfway through the usual dosing interval. For convenience, we recommended starting infusion at the conclusion of administration of loading doses. So this is the diagram showing the drug concentration time profile for varying dosing strategy with time-dependent antibody. Hypothetically, the drug clearance versus time data following single administration. So A demonstrate continuous infusion without bolus dose, and the B demonstrate bolus dose followed immediately by continuous infusion. C demonstrate an extended infusion over 4 hours, and D demonstrate the dotted line represents the minimum inhibitory concentration of the infective organism. So Lodis and colleagues examined the role of extended infusion of piperacillin tazobactam in the retrospective cohort of clinically ill patients with Pseudomonas aeruginosa infection. Extended infusion were associated with significant improvement in 14-day survival in those patients with higher clear illness severity. Similar retrospective analyses have been performed in patients with ventilator-associated pneumonia with gram-negative bacilli with continuous infusion of meropenem, ceftazidime, piperacillin, tazobactam, all associated with improved rate of clinical cure, particularly with more difficult to treat organisms. In a small prospective study, Robert et al. Reported clinical advantage to continuous infusion of ceftriaxone when patients receive 4 or more days of therapy. However, systematic review and meta-analysis performed in 2009 reported no significant clinical advantage to continuous infusion of beta-lactam in hospitalized patients. More recently, the Falagas and the colleagues repeated this analysis, focusing on piperacillin, tazobactam, and carbapenem. Overall, lower mortality was demonstrated with the extended and continuous infusion, although only 3 of 14 included study were randomized controlled trial. Contrasting findings were recently reported from the single center before and after study in which extended infusion of beta-lactam appeared to offer no advantage over intermittent dosing. Concurrently, multi-center, double-blind, randomized controlled trial of continuous infusion of beta-lactam reported improved improved this therapeutic MIC, time concentration, time-dependent MIC, and clinical cure in critically ill patients with severe sepsis, although no significant difference was noted in ICU-free days and survival to the hospital discharge. Vancomycin represents the other most studied agent, although data are currently conflicting on the clinical efficacy of continuous infusion. Specifically, Relo et al. In retrospective match cohort analysis described the clinical superiority of the vancomycin infusion in patients with MRSA ventilator-associated pneumonia, although a large prospective multicenter study failed to demonstrate any significant microbiological and the clinical benefit to the continuous dose. A recent systemic review and meta-analysis has demonstrated comparable result, although lower risk of nephrotoxicity in patients receiving continuous infusion. The use of continuous or extended infusion of antibiotic in patient manifesting the augmented renal clearance represents an attractive approach, although to date there are no prospective data comparing dosing regimen in this setting. However, a recent observational study by Carly Rectal suggests that despite the use of such a strategies, elevated creatinine clearance remains strongly associated with suboptimal beta-lactam drug exposure. This, in combination with inferior clinical outcome demonstrated in patients manifesting augmented renal clearance, indicates that higher daily doses are also likely to be required. This is supported by dosing simulation reported for vancomycin, doripenem, meropenem, imipenem, piperacillin tazobactam, in which adjustment in the total dose in addition to the use of extended and continuous infusion are recommended. Now about therapeutic drug monitoring. Therapeutic drug monitoring is the commonplace in the prescription of aminoglycoside and glycopeptide. Although outside of these classes, it is infrequently available. However, the growing body of literature supporting PKPD optimization suggests that therapeutic drug monitoring is likely to be beneficial for a number of agents, most notably beta-lactam. Recent data have confirmed the utility of measuring beta-lactam concentration with dose adjustment required in approximately three-quarters of the patient. Limited uncontrolled evidence supports improved clinical outcome with beta-lactam therapeutic drug monitoring, although large-scale clinical investigation is still lacking. If accurate point-of-care devices can be developed to allow real-time dose adjustment, beta-lactam therapeutic drug monitoring will hopefully transition into wider clinical practice. Logical recipient would include those with significantly deranged pharmacokinetic or where intermediate pathogen has been isolated. Now, PKPD modeling for empirical dosing or in the absence of therapeutic drug monitoring, improved antibiotic dosing strategy are urgently needed to optimize clinical outcome in critically ill. Integration of physiological, pharmacokinetic, and susceptibility data in robust PKPD model derived from the critically ill cohort should yield dosing recommendation that have greater likelihood of achieving optimal drug exposure. While few outcome data are available, Dalfino and colleagues recently validated previously established PKPD model of colistin administration in critically ill. Higher rates of clinical cure without a significant renal toxicity were demonstrated. In future, large controlled clinical trials should be planned to validate such a dosing strategy for a variety of antibiotics in the ICU. Thank you, guys.